give an impromptu introduction to my friend and mentor, Dr. Mark Siegler, who doesn't need much of an introduction. He's the Lindy Bergman Distinguished Service Chair of Medicine and Surgery at the University of Chicago, founded and has led for 25 or so years, is that right? 25? The McLean Center for Clinical Medical Ethics, which I've had the privilege to be a part of the last 10 years or so. And that center has trained a lot of the physicians and other leaders of ethics centers around the world. And again, Mark has been a really terrific supporter of this program. He's going to moderate this next session, which tries to kind of explore how the ideas that have been talked about hit the ground in experiences of practicing physicians and patients as well. Mark.
Far, thank you so much. I'm delighted to join you to chair the session, Reflections and Application to Clinical Medicine, of the work that's been presented earlier today. We have four wonderful panelists in order: Reverend Daniel Hall, Andrew Michel, John Yoon, and John Hardt. I'll introduce Dr. Hall first. Dr. Hall is an assistant professor of surgery at the University of Pittsburgh. He earned his degrees in medicine and theology from Yale before completing his surgical training. Dan is an ordained priest in the Episcopal Church and was the first John Templeton Fellow in Religion and Medicine at Duke University, where his research focused on epistemology, moral philosophy, religious measurement, and the role religion plays in the context of clinical medicine. His current research examines the ethics of surgical practice and specifically how patients and surgeons negotiate the process of informed consent. Dr. Hall will relate the ideas discussed today to the practice of surgery. So please join me in welcoming Reverend Dr. Dan Hall.
It's wonderful to be here, an honor to be a part of this entire process, and a great opportunity to reflect with my fellow panel members and those who have come before. I'd like to start by noting that I think it is ironic that I am able to stand here before you because I have a grant that protects my time from my clinical duties as a surgeon. And what is it about those clinical demands that require protection from it in order to engage in the reflective process of understanding what it might mean to be a good surgeon or to put the practice of surgery in the context of good life. I'll also start by saying that Dr. Curlin has stated that we are currently at a historical high point for medicine's power as a social pretense. And as a member of the Guild of Surgeons, I am of the priestly caste of that power and pretense, with all due respect to my non-interventional colleagues, both here and outside. And that is why I very much enjoyed a particular comment from Verhey and Kinghorn's paper, which said that medicine can then once again be a humble ministry that takes its place alongside public sanitation, clean water, and the relief of poverty, which I think is very much to the point, and that's part of what Dr. Verhey was trying to get to, but time ran out. So if I am one of the priestly caste of surgeons, I am not one of the high priests of the super specialists in transplant or cosmetics surgery or neuroscience surgery. And that was a deliberate choice shaped by my apocalyptic imagination. I am, if this is not an oxymoron, just a humble general surgeon. I do, by choice, emergency general surgery. I don't do gender reassignment surgery. I don't do breast augmentation surgery. That would be within my skill set, but I don't do it. I don't do bariatric surgery, which is closer to my own discipline. And I have deep reservations about transplant surgery of almost every kind. And I apologize, Dr. Siegler. I know that we're different in this regard. What I do as an emergency general surgeon is I clean up after the mess that is left by the high priests, in the notion that I take care of fulminant Clostridium difficile colitis in the patients who are 2 weeks out from their redo double lung transplant who are immunosuppressed. I take care of the acute acalculous cholecystitis from patients who have a BIVAD device waiting for their heart transplant. I work at Pittsburgh, which is a big transplant center. I'm also the guy that takes care of the mess that none of the other surgeons want to take care of anymore, whether that be appendicitis in the middle of the night, free air on the upright chest x-ray, or dead gut. And I am deeply suspicious of those sort of self-promoting technologies that have, to me at least, little clear value, like the robotic thyroidectomy, which will take out your thyroid through an incision in your armpit simply to avoid the 1.5 centimeter scar that might be on your neck, or the single incision surgeries to take out your gallbladder to, again, avoid. This might be relevant for Christy Brinkley, but it's not relevant for most people who have gallbladder disease. So these, I think, are some examples of how my apocalyptic imagination, which has been shaped by my Christian commitment and the community in which I live, have changed and shaped the way that I practice medicine. And I think I want to say one other thing about why it was I became a surgeon. And there's something along this line in the essay that I wrote for my application to medical school, that as I was going through the 3rd and 4th year of medical school, the wisest physicians that I encountered seemed to be surgeons. Because it seemed to me that the practice of surgery exposes surgeons to a depth and breadth of human experience attained in very few other practices. Having your hands literally up to your elbows in blood and guts and feces and pus is really powerful stuff. And as Silmasi states, not all have the capacity to witness those things and remain whole. The wise surgeons who I noted were those that, for whatever reason, religious or otherwise, had the capacity to interact with that depth of the human experience and learn from it. Those that are more stereotypical of the surgical guild are the ones that become hollow shells by encountering that depth of the human experience without the capacity to make sense of it in some way. And I thank Dan for perhaps reshaping what I've grasped, I've sort of groped at in some of my own writing, and my intuition that I had there as a 3rd or 4th year medical student has been reshaped. That to learn as a surgeon and having my hands up to my elbows and that sort of stuff is not just to learn about the human condition, but it teaches me also about the divine condition as well. To know the suffering of my patients is to know the suffering of Christ, and it is his blood and pus and feces that I manipulate with my hands each day. And I find it very moving to see myself perhaps as holding Veronica's veil. Now, in many ways, this concrete embodiment of surgery resists the mind-body dualism that is so pervasive in the West. And in sympathy with what Rabbi Dorff had to say about the Jewish resistance to dualism, I will at least gesture to the fact that to the degree to which I have been attentive to the Hebrew scriptures, which we call the Old Testament, it has and continues to be a great resource to me in resisting that modern dualism that afflicts my formation as a very white Anglo-Saxon Protestant trained at Yale. And as things currently stand, the contemporary medical community seems to be characterized by deep skepticism. This is what Farr was sort of trying to say, that the contemporary medical community seems to be characterized by a deep skepticism about any right-hand sense of medicine against which the current social pretenses can be called to account. And I agree, where are you, Farr? I agree with your comment there, but I think that there is, and there have been gestures to it in some of the comments that have been coming forward, that just to the extent that we encounter our patients, we keep coming up again something that is like a right-hand sense of what it might mean to be a physician. And there is something intrinsic in the practice of surgery, which I think is different than the practice of internal medicine or psychiatry, in that I have to encounter actual tissue. This gallbladder, with this deformation from this disease, with this amount of inflammation, I can only do so much to. And that limitation of having to deal with an actual embodied body in the technical way that surgeons do continues to reinforce and provide some sort of right-hand sense that, again, I don't think is quite as fully articulated as what you and I both perceive, but there is something there yet intrinsic in the practice of surgery, at least, which provides some grounding to what that right-hand practice might be. And I would also say that there's something that you sort of talk about how the current practices don't necessarily have a telos or a teleology. But again, in the practice of surgery, there is that telos just to the extent that it's coming out. You know, I've gotten in so far that I can't get out of here unless this colon or this tumor or this appendix is actually coming out. And that is the goal that does, in fact, drive what we do. Okay, the next, I wanted to speak a little bit about what Stanley and Jerry had to say. They speak of how the Christian tradition may provide a suitable language for people facing the radical disruption of illness with hope and with joy. 5 minutes? Okay. And in this, I agree, but I want to make a few points. First off, although inguinal hernias can grow to become radical disruptions in our lives, I mean, I have seen that, most often they are minor inconveniences and do not constitute the sort of existential threat or occasion for surrendering control to the Almighty that you both are speaking of. And sometimes it's good to just have a decent mechanic to simply fix the problem. All of which is to say that not all kinds of illness are equally suited to occasion joy, and the practice of medicine, or at least surgery, requires some prudence in this regard to judge rightly the kinds of conditions that might occasion the radical disruption that could afford the opportunity to understand joy in a different and deeper way. Second, in establishing the limit of the responsibility or capacity of medicine to control, okay, this is much of the argument that they were making, I find that personally to be a huge relief and release, both to be more honest and vulnerable with my patients and to allow myself to sleep a little bit easier at night. And rightly or wrongly, I do perceive that as someone formed within a tradition that imposes those limits on the practice of surgery, I perceive a difference with some of my colleagues in my ability to hold what I do very seriously, not to be callous, but hold it lightly. And then I think the last thing that I want to say is this. I had a patient a couple months ago who came in with what appeared to be dead gut. And I thought, in fact, that it was going to be because he had a blood clot that had lodged in one of his mesenteric vessels. But when I got in there, in fact, it was a tumor growing around those blood vessels. And about half of his intestine was dead, and I was able to remove that. The other half was alive, but I could not render him disease-free because the tumor was encasing the very root of that major blood vessel. If I were to take the tumor out, I would have taken out all of his intestine. And he would not have been able to survive that way. So to be able to come afterward with the patient and the patient's family and to speak the truth quite bluntly, I cannot cure you. I did not cure you. I'd laid the groundwork before, in fact, along these lines, and be able to shift and say, you will die from this. I can't tell you when, I can't tell you how, but we now know how you're going to die, but we don't know when. But then to be able to, having told the truth, to begin to focus again on what it is that he could do with the time that was left, because I preserved the rest of his intestines so that he could live for months or years. To be able to focus on that, I usually use the terms of sort of saying, do what is most meaningful to you in your life, try to refocus along those terms. But I think that after having read both, all of these papers, I think I may more explicitly try to use the language of joy, even though that is going to be disruptive to people because it's going to be hard. And I wonder to what extent, without transgressing the very important boundaries of witness versus evangelizing, what it might be for me to be able to engage then as a human being at the same level, sitting down and say, you know, something about my experience as a human being who attends many people in these positions. There is something mysterious about the fact that when we are rendered out of control and when there seems to be so much suffering, that is when God is most near. And just to be able to say that as a way of beginning to witness and transform the kind of interaction that we have as patients and doctors alike. Thank you.
Dan, thank you so much. I will have a chance to return to your concerns about transplantation in the discussion period. Our next speaker is Andrew Michel, an assistant professor of psychiatry at Vanderbilt, where he coordinates the psychiatry residency experiences at the VA hospital, while also working in the VA's outpatient mental health clinic. Dr. Michel is an affiliate of the Center for Biomedical Ethics and Society at Vanderbilt, where he was formerly a Stallman Scholar. His scholarship is focused on engaging clinical medicine, particularly clinical psychiatry, from a virtue ethics perspective. As a clinician, Dr. Michel has been working to develop a psychiatry practice that intentionally is relational in structure, centering on supportive and insight-oriented therapy and using medication when indicated. Today, he will relate in his discussion his experiences to clinical psychiatry. Dr. Michel.
Fark Herlin, in his paper on irony, makes the following claim. In the end, how physicians respond to irony will determine if ironic experience leads to renewed efforts to realize a better medicine, or results only in detachment from and cynicism regarding medical practice as a way of living a good and faithful life. As a clinical psychiatrist and now as a teacher of physicians being formed in the practice of psychiatry, I think that there is something critical to this ironic moment. Ironic experience either leads to despair and to giving up, or to a creative engagement with life and pain. It resonates well with my personal experience and with what I've heard from colleagues. The practice of psychiatry is not a glamorous one. Dan, if surgeons are of the high priestly caste of medicine, then as a psychiatrist, I would be a peasant in the kingdom. We are as stigmatized as our patients. First of all, we to date, and I'm just being honest, have no diagnoses that have been well validated. Everyone knows that we have the habit of changing our diagnostic system every 10 to 15 years, and we're about to do that again in 2013. Diagnosis in psychiatry, therefore, is an inevitable ambiguity. Not only that, but the psychotropic technologies we have at hand do not appear to be very effective. At best, they have marginal impacts beyond placebo, and I am very grateful for the placebo effect. But they unfortunately carry a load of problematic side effects. What is abundantly and tangibly clear to me and many others who see people suffer or who suffer themselves is that patients are suffering, however we want to talk about that, whether using DSM criteria or other ways of speaking about psychiatric illness. They come to the clinic in significant mental anguish, seeking answers and relief. It is admittedly hard to sit in these ambiguities, and it is still harder to be present with patients in their pain. Psychiatric illness, whatever it is, can be really bad, and practicing psychiatry well is a significant challenge. I was struck by Dr. Mormon's comments and the way that we might understand the work of being a caregiver or a physician as a kind of trial or a testing that would require virtue, especially patience or long suffering. And it seems to me that when my patients come to me hurting and in pain, it's often the case that I am there with them in that pain. And given the limits of my technology, it can be a hard place to remain. What can sustain me in such a practice? What might allow me to lead a good life as a physician? Into this chasm, far Kurland steps, taking up with Kierkegaard as unraveled by Jonathan Lear in his work, A Case for Irony. Can a 19th century Danish philosopher help me to continue on? I must say he seems an unlikely savior. Kurland writes, this essay seeks to describe the conditions that make it possible for physicians to respond to ironic experience, not by burning out, but rather by renewing their quest to become the physicians they are not yet. Irony can serve medicine as a symptom of problems in our current practices. It can help physicians detach from current practices while committing themselves more firmly to the medicine toward which those practices aim. It can serve as a resource for continuing to practice medicine despite not knowing quite how. If Kurland is right, then this ironic moment is not trying to throw us off into the abyss of despair, but rather to invite us on a quest to realize a different way, perhaps a surprising way forward. According to Kurland, and in Lear's work, describes irony as the uncanny experience of being personally confronted with or arrested by a gap between the totality of available social expressions of a practice or practical identity, and that practice or identity toward which the social expressions aim, but inevitably fall short. One of our struggles in the contemporary landscape of medicine may be that this gap is widening, which makes irony all the more apparent and perhaps overwhelming. It's difficult to respond to. The first problem seems to be true for all of us as humans living in the strange, late modern world. Vocational clarity is diffused, elusive, and whimsical. It's less and less clear what one should do and when. We no longer know in what way to put ourselves forward. Because we are finite, we must put ourselves forward if we are to be courageous in some particular way. But the choices around how to do that seem immense, and the available social roles appear constrained or unworthy. The resulting ambivalence can be paralyzing. The problem is that as soon as we put ourselves forward, we admit a failure. As Lear puts it, in putting myself forward as a physician, or whatever the relevant practical identity, I simultaneously instantiate a determinate way of embodying the identity and fall dramatically short of the ideals that I have until now assumed to constitute the identity. It's one reason why we may become arrested. At the same time, it seems to me that roles are more and more constrained, more and more determined by socio-political forces beyond an agent's control, as highlighted in a lot of the papers today. In my current practice at the VA hospital, I am expected to see patients every 20 to 30 minutes, and my clinic is currently backed out about 3 to 4 months. There is hardly space to allow for a patient's illness narrative to emerge organically under such impoverished conditions. Instead, the patient and I are forced into a dialogue around psychiatric symptoms in a biomedical frame, and the collapse of time makes a psychotropic solution, which is quick and efficient, all the more appealing. I have concerns about this. Instead of psychotropic technologies coming to assist patients in deepening in relationships with themselves and others, they are increasingly coming to be understood as a means of making such relationships unnecessary. There is little space for creative engagement with the role, for flexibility to fit one's delights to the socially available manifestations. Instead, there is an overbearing consensus of professionalism, in the bad sense of that, and an evidence base that would seek to make the practice of medicine a packageable commodity that can be mechanized, standardized, shipped, bought, and sold. Kurland articulates 5 dynamics that serve as obstacles to moving forward as a physician who practices with excellence. Of the 5, I find the complex industrial bureaucratic system to be the greatest giant in the promised land. As Curlin notes, to the extent that medicine becomes structured by complex industrial, scientific, and bureaucratic systems, physicians then face another hurdle endemic to the modern age, which is the sense of learned helplessness in the face of the overwhelming complexity of the systems that govern social life. Making good use of irony requires a sense of possibility, a sense that the gap between the current social pretense and a more robust version of the ideal can be closed in one's own experience and in response to one's action. Irony, Lear notes, calls for a human, not a superhuman response. Because the gap has widened, and because the task of becoming a good physician has been rendered so much the more challenging, it becomes easy to fall into the socially constructed pretense of the practice. Aspiring to something more is simply too painful, too fantastical. It is much more comfortable, and oddly comfortable, to imagine that if I complete all my paperwork just right, fill out patient symptom scales in an evidence-based manner, follow the algorithms for which psychotropic medication to apply toward this patient next, follow up on vitamin D levels, which when low are correlated with depression, and score high on patient satisfaction surveys, that I have been excellent as a physician. Though an easy accommodation, such a posture would be the worst kind of pretense, not the kind to which Lear commends us. No, if being complicit with the current hypermodern technocratic practice of medicine is considered good, then the way to be a good psychiatrist is decidedly to be a bad one. I may already be spending too much time in unironic self-reflection internal to the practice and self-condemnation over my failures to check every box on the clinical template. All of these constructions only leave me further resigned and make it impossible for me to bring joyful hopefulness, a nod to Kinghorn and Verhey, to patients who are desperately in need of it. Likewise, the more time I spend trying to meet the standards of being a professional, the farther away I seem to get from the heart of what it might mean to profess something. These confusing realities make it harder than ever, as Lear puts it, for physicians to hear the right-hand resonances of their practical identity. I am reminded of another of Kierkegaard's notions, which he outlines in his work, Fear and Trembling, that of the night of infinite resignation in contrast to the night of faith. The behavior of these two nights may appear exactly the same. They may both be in the clinic doing their work. They may both find themselves to be somewhat effective in helping patients. Both may get good ratings on surveys of patient satisfaction. They may even both grumble against the work at times. However, the night of infinite resignation is set on fulfilling his duties. He is burdened and glum and cynical. He is enslaved to the finite, to the ethical. Another way of putting it is that the night of infinite resignation knows that his pretense is hopeless and irredeemable. His pretense can never be realized as perfected. He is dead before he starts. In contrast, the night of faith, while performing her duties in the contingent realities of concrete life, is somehow freed up into the eternal. As Kierkegaard says it, it is on the strength of the absurd that the night of faith makes such a paradoxical movement. In finding herself fixed, dead, like a specimen, in the pretense of being a physician, she yet finds herself perfected in the absolute. In the reality of her imperfect finiteness, she is transfigured into glory. In dying, she lives. This thing Kierkegaard calls faith allows her to go on with a different posture toward the world. It is a posture of hope. It is the night of faith who sorts out how to live well, and in radical hope, a nod to Jonathan Lear's other work, in the face of ambiguity and despair. As Lear notes, done well, ironic existence would be a manifestation of a practical understanding of one aspect of the finiteness of human life, that the concepts with which we understand ourselves and live our lives have a certain vulnerability built into them. Ironic existence thus has a claim to be a human excellence because it is a form of truthfulness. It is also a form of self-knowledge, a practical acknowledgement of the kind of knowing that is available to creatures like us. So, My life as a physician, as a psychiatrist, hangs in the balance. I have real moments where it is unclear to me that the practice of psychiatry in its contemporary manifestation is worthy of my energies. In ironic moments, I am arrested by the impossibility of going forward. It is unclear to me what taking on the practical identity of being a psychiatrist has to do with living well. It feels as if all is in vain. Still, I am not without hope. Despite contemporary realities, there are moments where grace breaks in, like an apocalyptic dawning. I find myself somehow able to hear the patient. I may even discover that I have a word of comfort or guidance or encouragement for them. We may simply find ourselves able to share some silence together. I can keep going, though I don't know quite how. For me, this is a daily pilgrimage for which I require daily bread to sustain me. Better put, meaningful moments with patients are my daily bread. Thus far, I have found provision to continue onward. I know not what tomorrow brings. While I might be enabled to live ironically, the reality is that I must eventually lose myself in my art. The next patient needs be seen. There is little time for formal prayers, only, Lord, have mercy. As I call the next patient out of the waiting room and take up my mantle in pretense, I no longer worry about such matters. I am fixed in action, fully surrendered to the practice. It is like a great slugger who simply swings the bat. Thank you.
Thank you, Andy. Thank you so much. Our next speaker for the panel will be John Yoon, an assistant professor of medicine here at the University of Chicago. John is part of the core faculty both in the McLean Center and in the program on medicine and religion. As an academic hospitalist, physician, and a medical educator, John has maintained research interests in the field of virtue ethics, moral psychology, and the moral and professional formation in medical education. He currently is working with Dr. Kurlan on a program that they call the Project on the Good Physician. This is a national study of the moral and professional formation of medical students. That project is funded by the New Science of Virtues Project here at the university. Dr. Yoon will relate today's discussion to his experience as a practicing internist and hospitalist. Dr. Yoon.
Thank you. And I'm very grateful for the privilege of spending time with the working group members and the privilege to speak before you today. I'm an internal medicine physician, and I don't know where we stand in terms of the temple society. Surgeons are the high priest, and psychiatrists are the peasants. I don't know, maybe among the primary care physicians we're the sacrificial lamb. But again, I'm a hospitalist, and in my practice of medicine, I often find myself asking the question that Dr. Kurlan highlighted: what does any of this have to do with being a physician? I'm also a Christian, and when I go to church, I not infrequently find myself asking, what does any of this have to do with being a Christian? So although we are focusing on the practice of medicine here, it seems to me that the ironic question, whether experienced as true irony or as a mere sense of the incompleteness of life, this question is central to the human condition. It is certainly central to my experience. Building from Dr. Somesi's remarks on witness, as a clinician, I try to bear witness to or focus attention on those arresting, disruptive moments in hopes of recognizing how we fall short and finding a better way to go on. In doing so, I resonate deeply with Dr. Verhey and Kinghorn's suggestions that these moments can be interpreted theologically as moments in which the world to come momentarily breaks in. In light of this thought, I've pondered a bit about a clinician's version of the prayer of the sick person that Dr. McKenney and Dr. Hauerwas quoted at the beginning of their talk, to do nothing gallantly. Therefore, I would like to propose the prayer of the burned out doctor, to do one small thing gallantly. I mention this because I confess that as a practicing clinician, I find myself swinging from one extreme to another. At times, I swell with the anger of a fiery activist, wanting to fight frenetically and angrily to usher in the world of my own medical messianic expectations and hopes. I feel a sense that something very good is being lost in medicine, and I can tell why and who is responsible. Perhaps a bit like the great Sioux chief Sitting Bull, who, as Jonathan Lear describes in his book Radical Hope, fights with fury against the end of the world as he knew it, resisting the impending power of his age. Like Sitting Bull, I too want to resist the powers of our age, the forces that seem to be sapping the joy and meaning out of medicine. Yet, at other times, instead of trying to do everything frenetically, I want to do nothing fatalistically, particularly in the face of a healthcare system that seems too complex and imposing to change in a way that actually benefits the patient. It feels truly like going against a power and principality in medicine, as Dr. Verhey and Kinghorn describe in their paper, one which is a power which is far beyond my ability to overcome. So I want to give up. These internal experiences mark my day-to-day practice of medicine, so I find it difficult to practice good medicine and to be the kind of doctor I want to be. As an educator, I often want to do nothing fatalistically in the face of inflexible work hour restrictions that make it nearly impossible to teach effectively and meaningfully to our younger generation of physicians. I feel even more powerless trying to work against the hidden curriculum in medicine. It is bad enough that I work in a culture of medicine that implicitly opposes the very virtues that physicians explicitly profess. But worse still, I find that I am woefully inconsistent in upholding those virtues in my own practice. Without any realistic hope for positive change, I am tempted to do nothing cynically, to carve out for myself a cave of refuge, hunker down, and ride out the storm, while medicating myself with Korean TV dramas on The Good Doctor. Side note, if you haven't seen the DVD series Daejanggeum, you really should. So as Dr. Verhey and Dr. Kinghorn mentioned in their paper, part of me longs for that medical night of faith. And Abraham, or Sarah, of clinical medicine, or in the modified words of Paul Ramsey, an Abraham or Sarah of clinical medicine, if one should arise, would be one who, when all hope is gone, hopes on in faith, and therefore need neither fear the problem nor trust the solution of it too much. In my mind, this person is the clinician who, in the day-to-day challenges of their practice, never fails to do that one small thing gallantly, and does it with joyous hopefulness. During my own medical education, our clinical exemplars told us stories of such individuals, even if those stories only foreshadowed distantly the real deal. For example, one of my physician role models in internal medicine was Dr. Daniel Foster from UT Southwestern in Dallas. Dr. Foster often told the following story during white coat ceremonies. I'll read an excerpt that he recounted in 2007. He wrote, "It was the day of President John F. Kennedy's assassination, where he died in Parkland Hospital, which is our main teaching hospital. The chief resident in surgery then was the late James Carrico, who subsequently became our chair of surgery. Parkland takes care of the medically indigent in Dallas. And he had been called down. There were 2 patients that needed surgery. One of them had a mechanical intestinal obstruction, and the other had a thrombotic leg with gangrene. Both needed to be operated on. While they were in the emergency room, the word came that the president had been shot. James Carrico was the first person to see President Kennedy when he got there. He immediately started fluids and started steroids. As you remember, Kennedy had adrenal insufficiency, and he remembered it. The Parkland resident remembered that. It was, as you know, to no avail, and the president died. Then Carrico, the chief resident, came back down to the emergency room and took the woman, an uninsured Parkland patient, up to the operating room and operated on her. And when he was through, he went home. When he went home, his white coat was covered with blood, and it was a mixture of blood. It was the blood of the President of the United States and the blood of an uninsured Parkland patient. And in passing, I told the first-year students, true physicians take care of the rich and the poor, the famed and the unknown, in the same way. But when Jim went home, he felt something in his pocket of his white coat, and what it turned out to be, he reached his hand in, it was a piece of the skull bone from the president's head. When they had tried to move his head to see what they could do, it had apparently just fallen off and slipped into his pocket. He ate supper, and then he went into the backyard. He told me later he realized he should have saved this, but he burned the white coat and buried the bone. He burned the ashes and the bone of the President of the United States, and then the next morning, he put on a clean white coat and went back to Parkland. Dr. Foster would then tell us medical students, that's what true physicians do. They're not defeated by defeat. Back then, we didn't have professionalism lectures. That was all we got. But as a medical student, the lesson I learned from Dr. Foster's story was clear. In the face of what seems to be apparent defeat, you get up the next morning and continue to do one small thing gallantly. Dr. Foster's story recently came to my mind when I reflected on a disruptive moment during my own internal medicine residency training, a time when I struggled to move forward in the face of defeat. For every internal medicine resident, their rotation as a supervising resident in the medical ICU is nothing short of trial by fire. I remember one day during my own month in the ICU, I was caring for a critically ill patient with end-stage kidney disease on dialysis who seemed to be in septic shock. It had been a pretty good day. I had successfully intervened with a life-saving intervention on one patient, taught an intern how to put in a central line, and stabilized most of my critically ill patients. I was feeling pretty proud of myself until I sat down to check labs of my patient with septic shock. During the heat of the initial moments of responding to the patient's shock, I had opted to send her down for a CT scan, but I had neglected to check her potassium level before doing so. When I looked at her labs, I saw that her potassium level was critically high. Panicked, I text-paged my intern who was accompanying the patient to the CT scan. "How's our patient doing?" I asked. The second after I sent the page, I hear on the overhead intercom, "Dr. Hardt, CT radiology room," the message indicating that a patient had suffered a cardiac arrest in progress in the CT radiology room. After blurting out a word that Christians don't normally use in church, I rushed down to the CT area to find my intern frantically performing CPR on a patient who died short time later. Shocked and crushed, I found myself in an elevator on the way to talk to the relatives of the patient who were waiting for me to update them on their loved one's condition. Not knowing what exactly to say and having oppressive visions of me in a courtroom on trial for medical malpractice, I began rehearsing in my mind a risk management speech to the family. It appears that your loved one has suffered an unfortunate chain of events that led to a poor and unexpected outcome. But when faced with all the penetrating looks of every family member, the words I could only manage were, "I'm so sorry, I should have, I thought she was safe to go, there was a mistake, I should have," and then completely lost my professional composure and broke down. One of the older relatives of the patient gently came up to me with tears in her own eyes. "Doctor, we knew you did the best you could. The Lord decided it was time to call her home. We hold nothing against you. You did the best you could, and we thank you for that." Before that moment, I felt that my career in medicine was over, the defeat too crushing to overcome, and yet the grace the family showed to me was almost otherworldly, breaking into my own broken world of imperfect medicine, giving me hope to move forward again, giving me hope to continually do the one small thing gallantly. Though this time it was the patient's family who did the one gallant thing for my sake. Dr. Solmesi mentioned that Christian witness is normally thought of as going from the direction of the physician to patients and their families, but in this case, the witness went the other way. My church family and community I've grown up with, many of them who are here actually, have always taught me that God is present in the small things. I'm reminded of the gospel message that the kingdom of God breaks into our world like a small mustard seed that later grows into a big tree. I'm reminded of the book of Daniel and the Hebrew scriptures in which a rock in King Nebuchadnezzar's dream starts out small, but grows to become a big mountain, ultimately bringing down all the empires, powers, and principalities before it. And I'm reminded of the Christian story that a baby in a manger also broke into this world, small and virtually unnoticed, later dying on a Roman cross in apparent defeat, that is, until Easter. In the face of apparent defeat and hopelessness in the practice of medicine, it seems to me that a Christian response, as a clinician then, is to humbly move forward with a critical realism, but also a radical apocalyptic hope. And to do so by faithfully disciplining ourselves to do the one small thing that we can do gallantly for the patient in front of us. Thank you.
John, thank you very much. Our final speaker on the panel will be John Hardt. John is the assistant to the president for mission and identity at Loyola University in Chicago and is an assistant professor of bioethics at the Neiswanger Institute for Bioethics and Health Policy at the Stritch School of Medicine. John's research and writing has focused on professional ethics, end-of-life care in the Catholic tradition, neonatal ethics, and physician conscience in the clinical encounter. His teaching portfolio considers issues in religion and medicine with special attention to the Catholic moral tradition. John is a PhD in theology and also completed our McLean Center Clinical Medical Ethics Fellowship and worked for several years providing clinical ethics consultations in Catholic hospitals. Today, John will comment on how some of the ideas discussed connect with his experiences helping doctors and patients make difficult moral judgments about medical care. Join me in welcoming John Hardt, please.
This is how the panel ends, not with a bang, but a whimper. So I'm going to work to be brief. Indeed, I'm a theologian who teaches in a medical school and does ethics consultation, but I've given a talk at the University of Chicago on my failure as an ethics consultant, and I'm too young in my career to repeat that talk. But the general gist of it, using the language of today, is that I think one of the great threats to clinical ethics consultation is that we become co-opted by the power of medicine. To borrow from Warren and Allen's paper, in a bad sense, insofar as we become tools or vehicles for achieving the ends that a clinical care team seeks. Get that DNR. Let's get this patient discharged. Let's get an agreement on withdrawal of life support. Let's get them to agree to a time-limited trial. Versus what I think a good clinical ethicist is called to do, which is to be a witness. I've begun to think about my work as a clinical ethics consultant as a person who's called in to try to see things clearly. When anxiety and tension and frustration tend to cloud our vision, the outside look of an ethics consultant can sometimes clarify that. But given that, what I'd like to do instead is to talk about a case that would never come to an ethics consultant, because no moral principle was ever violated, a standard of care was met, the left side of the physician's identity in the practice of medicine was fulfilled, as Farr would ask us to do. And as it so happens, it's an autobiographical case. It's the story of my wife's second miscarriage, which actually happened over the course of our meetings with this group. And by the way, it's been the professional privilege of a lifetime to be in all of your company, so thank you for that. I thought I'd just read this brief case write-up that I did and haven't shared yet, and then just very quickly just draw a couple lines of connectivity before we start our discussion. As time would have it, it was said at a wedding reception that, had things gone otherwise, would have been our due date. She came to our table as dessert was being served. "What's wrong with you two? Why don't you have another? Seamus needs a sibling, you know." We knew too well. I watched as my wife's shoulders quietly rose and fell as though, being attentive to time and place, she were trying to discreetly dislodge an avalanche of grief gathering since the miscarriage of our second child, that aforementioned sibling, the baby we wanted and loved. I controlled my anger in the moment, but this unintentional hurt rekindled my resentment at a host of clinical missteps that gathered around us in this most common experience of miscarriage, this death in our lives. I can account for my friend's remark at a wedding reception, too much wine, a celebratory atmosphere, a sincere desire for us to have more children. It was uncouth, but forgivable. But I have a harder time accounting for this experience, and I'd like to approach this particular clinical encounter through the eyes of our authors who've spoken today. "Oh, there's nothing there," said the ultrasound technician as the wand paused over my wife's gelled flat stomach, casting onto the monitor the grainy black and white image of an empty, dark womb. The lighthouse flash of a heartbeat made miniature was extinguished. That rhythmic waterlogged audio of its early work rendered silent. Here began the first time we cried that day. A mindless stream of trite comments followed. The technician's intention was good, but I so badly wanted her to know better. "Oh, honey, it happens," she said to my wife. The unwarranted familiarity of address landed with a thud, a warning shot of what was to follow. "I mean, this happens all the time. Do you know how high the miscarriage rate is for women your age?" "Yes, we do. But this loss of this nascent human life, our baby, is ours alone right now. No percentage of frequency is going to diminish the particularity of this experience in our lives. You'll get over it in time, she said. Thank you for demonstrating your predictive powers, I thought. Please be quiet. The technician and I left the room, she to find a beating heart in someone else's womb, and I to stand outside the exam room door waiting. My wife was to get dressed and join me in the hallway, and then the nurse would call the obstetrician. She was in the hospital and we in the clinic, for us to speak with her by telephone. 5 minutes passed before I opened the door to check on my wife's delay. The lights were still dimmed. My wife was on the exam table, but now sitting upright. She rested her index finger on the monitor over the frozen image of that gestational sac, her last attempt at this particular human touch. I heard her say quietly, "We'll never know what he would have looked like." This, I thought, is a particular kind of death, a genus of which your child's gender is determined by fiat and the observation of the grieving mother. But it is a death no less, a death for us. In an instant, the place had changed. Signs of pregnancy abounded, with extended bellies protected by motherly hands as they maneuvered the narrow corridor in which we now stood. Opposite us hung a pinboard, previously unnoticed by me, covered with photographs of newborn babies, the fruits of this medical practice in 100 labors. We were the lifeless in this life-laden reef, dryly grieving among the anticipatory, the expectant, the teeming. The nurse hurriedly ushered us down the corridor when Michel came out. She dialed and handed the phone to Michel as we stood in a cramped hallway cut out with a stool, a shallow counter, and a wall-mounted telephone. There was neither privacy for the call nor pause on the other end of the line. "Hey, Michel, so I spoke with the nurse, and we have two options. You can either schedule the D&C, or you can wait to expel the pregnancy." Michel was heaving with grief, unsettlingly apparent to the patients and nurses that trafficked the corridor. But the same fact passed unnoticed by the physician on the other end of the line as she continued with clinical precision and the speed required of a very successful practice. "I recommend a D&C. Passing can be painful. You'll probably see some significant bleeding, and cramping can be pretty severe too. I think you'll find scheduling this more manageable." Then a pause. The doctor heard her crying. "Oh, I'm sorry. I should have said I'm sorry about this." It was as though she were interrupted by a memory of a medical school lecture on delivering bad news. Remember, it is helpful to communicate sadness and regret when appropriate. This is called empathy. The conversation continued for another minute, and then, as if talking to a patient who just underwent a healthy prenatal checkup, she said this: "Have a great weekend." We did schedule a D&C because we did anticipate that it would be more manageable. The uncertainty and fear that accompanied the alternative of waiting, what if it happened in the middle of the night or while she was at work with a client, was too much for either of us to consider for very long. We didn't anticipate this, however. "Is this really where you go for a D&C?" I barked at the orderly as we pushed through the door of labor and delivery. It was too much for Michel to bear. She sobbed while he rolled her into a small exam room just short of the nursing station, flanked by delivery rooms on both sides. We'd been here before, but for reasons of living, not dying. Just down the hallway there in 3C, our son had been born. "The doctor will be here shortly." Through the doorway, we watched two women arrive to deliver their babies while we waited for the doctor to remove ours, now dead. We sat next to each other on the exam table. I pushed the door closed with my foot, we leaned into one another, and we cried. The doctor came out to find me about an hour later. "Everything went fine," she said, and handed me some paperwork, including a copy of the report. "Spontaneous abortion," it read. "No," I thought, "our baby died. Can anyone see that?" Very briefly, because I know that we're tight on time, I just want to try to draw a few points of connection, and I really don't want to level this as an unfair critique of medicine or this particular physician. And the danger here is that I read too much into these interactions. She was having a tough day, she was busy, and that happens to all of us. But it occurred to me when this happened, and Stanley Hauerwas had mentioned this prayer about doing nothing gallantly, that diagnosis, miscarriage, called on my wife to do nothing gallantly, to go home that day and try to figure out how to wait, because there was nothing left to do. But what we so desperately needed and didn't get in that medical counter was the assistant that Dr. Moorman talked about today. But to be an assistant, we needed a witness. I needed someone to be able to see what had happened to us. I so badly wanted that doctor to have seen Michel touching that gestational sac on the screen. And we didn't have that opportunity. And I thought it would be such an instructive opportunity. I was reminded in thinking about this of that wonderful line from Marilyn Robinson's Gilead near the end of the novel, where John Ames, the main character of the story, says, "It seemed to me sometimes as though the Lord breathes on this poor gray matter of creation and turns it into radiance. For a moment or a year or the span of a life, wherever you turn your eyes, the world can shine like transfiguration. You don't have to bring a thing to it except a little willingness to see." This struck me as such a failure of a physician's ability to witness. But more importantly, this practice on the North Shore that delivers very healthy babies and does it very well, also suffered, perhaps to borrow from the language of today, of a lack of an apocalyptic sensibility. The practice couldn't accommodate the not yet of babies that aren't born. They couldn't accommodate the notion that we do death here too. My closing point. After all this happened, I work at Loyola Chicago, as Dr. Siegler mentioned. I talked to our chaplains there and asked them about how we handle miscarriage. And I was struck by a few things. One of our chaplains has instituted a program in which as soon as a miscarriage is diagnosed, the chaplain on call appears on the scene. A room is set aside for the conversation. And we're actually in the process at Loyola now of trying to make sure that women don't come in for miscarriages and get carried into labor and delivery for the procedure. I mention that because Dan Solmesi at the close of his paper mentions the concrete ways that we might see this kind of Christian practice lived out. And I'm quite proud to work at a place that's trying to take that seriously. So there's much more to say here, but I'm going to stop there. I apologize for running long, and I thank you so much for your attention and the opportunity.
These four moving talks are open for discussion among the panel or with the audience. I'm struck as I listen to them about how hard it is to be a young doctor these days, or a young health professional, as John is, and also I think I reflect on, from the point of view of the three physicians on the panel, how hard it is to practice medicine in a way that conforms to one's expectations and ideals. As one goes through the formation process that Far and John are studying now. On the other hand, there were a few names mentioned, and I'm sure each of you had his or her own names. Who was it who mentioned Dan Foster? Was that you, John? Yeah. Quoting from his white coat talk. And the great James Carrico, with whom I had the honor of serving on the American College of Surgeons Ethics Committee, which he chaired for a number of years. I mean, these kinds of models, I'm sure emerge for each of you. Dan, you must have yours, and Dr. Michael, you must have yours. And the idea that they exist out there made me think maybe it's not just the plight of being a young doctor, but maybe part of it is a plight of being young. That youth has to go through a kind of experience and formative process that lasts well beyond medical school and beyond training, to emerge as some of those models were for you. On the other hand, several of you spoke to an observation that Alistair McIntyre made at a talk that he gave in 1979 at a conference that Eric Cassell and I did in New York. Professor McIntyre said, the modern physician must fill three roles. The one role, of course, is the physician as scientist. The second role was the physician as magus, magical healer, magician. And the third role that the modern physician is called upon to fill is the physician as bureaucrat. And I think several of you, two at least, highlighted the difficulties of working within the administrative and bureaucratic constraints that the modern system imposes. I'm sure these constraints have gotten much worse since the time that I was young and I was training, or just after my training. Well, they were very moving talks. Would the panelists like to comment or respond one to the other, or shall we engage the audience?
I say we engage the audience.
Good by me. We have some time for questions. I would ask you to come to the mic, identify yourself by name and your experience, just a few words, and ask the question, please. Lisa.
I'm Lisa Lehman. I want to thank you all for your really very moving comments and responses. My question first is for Dr. Hardt, because I'm curious in your description of what you were seeking and what you felt was missing from that experience and the changes that have been made in your institution as a result of it. Do you think that those changes were uniquely Christian? And this gets back to our conversation this morning. Really, what does religion really have to add to our conception of medical professionalism? Was there something that was it really just the empathic doctor that you were looking for, and that perhaps internal to the practice of medicine, our conception of medical professionalism would have sufficed to achieve those same goals?
Yeah, no, it's an excellent question. And I was thinking about it today when I heard your response to the papers earlier. Is that not on? Or maybe it's not close enough. Can folks hear me okay? Okay. So very briefly, just to clarify, we got the treatment for the miscarriage not at my home facility, at a North Shore facility, actually, not out at Loyola. But it inspired me, working at Loyola, to say, hey, how do we handle miscarriage now that we went through this experience that I wish we hadn't? To your direct question, yes, a good empathic physician certainly would have done. And as I was thinking about these remarks, I had in the back of my mind Bart's delineation of medicine's proper role, and I'm thinking about Professor Hauerwas's work that says that sometimes we can ask too much of medicine, and there are things that a church or a community of faith offers that we shouldn't be asking medicine to offer us. What I think was needed was the physician who appreciated, as Dan says in his paper, one needn't be religious to have a sense of wonder and awe at the mystery of what you as a physician are invited into, which is this human encounter with life and death. And this most ordinary kind of death, right? I mean, in this active of practice, they must see at least a miscarriage a day, I would think, if not more. And yet they seemed completely ill-equipped to handle it. And as a matter of fact, they seemed quite built to try to get us out the door, so much so that we changed practices after the encounter. So what is the inspiration or intentionality that makes a practice like that say, we should do this differently because of the profundity of who we are and what we do as physicians? And in this most ordinary loss of miscarriage, we should think about this differently. At Loyola, is that inspired by a Catholic theological vision? Yes. I know that's the case. Need it be? No. But I know that that's the inspiration from which that move is being made at my home institution. Does that get at your question?
Right, absolutely. And I just think it's important to recognize, and I hope, that in non-religious institutions that we would have individuals in leadership that would be as thoughtful and concerned about doing what's best for our patients and lead to a very similar conclusion. What I think that your whole story also emphasizes and just reaffirms the importance of learning from our patients. What's interesting is that you were the patient who you were teaching your institution about how to do this better, and you were well positioned to do that in part because you were the physician too. But fundamentally, it was your experience as a patient with your wife that gave you the impetus to be able to do that.
Yeah. And just my last follow-up point to your point, Doctor, the question that sits in my mind is, what are the philosophical or theological narratives that are going to inspire us sufficiently to see something of an important moment, a moment of transformation or transfiguration, to borrow from Marilyn Robinson, in something as mundane as an early miscarriage. My bias is to think that religious traditions are better inclined or more inclined to do that, but I wouldn't want to say that that's exclusive.
Thank you.
I would highlight at a much more mundane level that in dealing with encounters of the sort that you and your wife had, the physician being there matters a great deal. I mean, there are times for telephone interactions, and there are times when telephone interactions are, particularly within the same hospital down the hall, are simply not appropriate to the circumstances or the conditions, and should never be done. Nevertheless, the literature shows that so many instances of breaking bad news about death happen over the telephone and not in person. Please, Rabbi.
Elliot Dorff, American Jewish University. First thing is, these were absolutely powerful presentations. I was sitting next to Professor Marty, and he pointed out to me how everybody was absolutely glued to you guys. And Far, we've really got to get this into the book. Very okay.
They saved the best for last.
There you go, right on. As one of the first, I agree. Right? First, just a footnote. There's a wonderful book that people who have, by Rabbi Nina Beth Carden, on pregnancy, on miscarriage and pregnancy loss, which a lot of couples that I've known and who have suffered through it have found a lot of meaning in. So just as a footnote. I don't remember, it's something like miscarriage and pregnancy loss or something, but Rabbi Nina Beth Carden. Andy, I have a good friend who's a psychiatrist at UCLA who tells me the exact same thing that you described. What he gets meaning out of, in terms of the personal stuff, is that he's able to arrange, in addition to his interactions, which are largely about drugs and things like that with patients, he's able to arrange that these people see some of the social work staff at the hospital, or in other words, he's able to at least talk to say to himself, I'm not doing this only as a pill dispenser. I'm doing this as part of the therapy of a person, and I'm trying to make arrangements so that other people are able to do the things that the medical establishment doesn't allow me to do. And then the other thing that really saves him personally is that he gets involved in a lot of, on a completely volunteer basis, although sometimes he gets paid for them, mostly on volunteer basis, in all kinds of preventive mental health things for teenagers and for all kinds of groups, right? I mean, as a way of doing the kinds of things that he can do, that he really wanted to do as a psychiatrist, but is not able to do. I mean, I felt you were really noble, frankly. I mean that very seriously. But I also felt really sad to hear about, how your practice is going. And I'm just trying to tell you that this friend of mine gets meaning out of these other things. I don't know if it'll work for you or not, but
Yeah, could I respond to that?
Sure, please.
Yeah. I do find that I want the actual work that I'm engaged in to be, for me, valuable, so that it's unsatisfying that all of that would be referred or triaged elsewhere.
Right.
The other thing about it is that in my experience, it's often the case that it's difficult to discern when and when not to make adjustments in the medications unless you have a kind of therapeutic relationship with the patient.
Right.
So actually to do the technical work in psychiatry, which may be in some ways a little unique to psychiatry, you actually have to have that kind of relationship. So the thing that I can do over time is get to know patients well, because they come in repeatedly, they call. The other thing I often do is overbook, small sacrifice, but to have patients in for urgent visits often, or at lunchtime and that kind of thing, to get more of that contact so that I can do the work that I need to do. But it's very much a compromised model because of the way it is.
Right.
But I'm
you
sort of-
game the system, basically. You do what you can within the
I
system.
do the best that I can within the system. And there's always that lingering question of, is it worth it?
Right,
And
Yeah.
might I do this in some other way elsewhere?
right.
Yeah.
John, there was, I'm on the ethics committee at UCLA, and we had a long series of discussions about medical mistakes. And at least as far as I remember the research, exactly what you did is what is the most effective thing to prevent a lawsuit, right? The lawyers will tell you, right? The lawyers will tell you, defensive stuff, right? Something happened, nobody made a mistake, it just happened, right? But the fact of the matter is that there's research on this, that simply, saying, I'm sorry, I wish it could have been different. There were some things that I would have done differently had I known, that's the kind of thing. If you're just looking just looking for that practical result, what you did is exactly right. Aside from the fact that it's the most honest result. And I think you can probably live with yourself much better, than that way. Dan, one last thing. I'm queasy. Talking about the blood and the guts and that kind of stuff, I've got a lot of respect for you.
Dr. Padilla.
So Asim Padel. So I have a question actually for you, Reverend Hall, then a reflection for all of you. So you mentioned something about I don't do cosmetic surgery, I don't do XYZ, but I do this. And the way I interpret that was that your understanding of the faith and your own personal proclivities led you to practice certain types of medicine. So I wanted to kind of think that to a level that maybe some people feel, again, some discretion about. Well, now if people in the society say, well, I'm not going to do certain types of medicine because I don't feel that's what I'm called to do, what does that have repercussions for society, right? Because, and the opposite is there's a scholar, I think Far, you work with her, who provides abortion and doesn't feel like she should be doing that, but she does that because she feels that's actually a mitzvah for her because other people won't do that, right? And so she actually thinks of it, well, I don't want to do it, but I do it because I have to demand for society. So if we start to have these sorts of things where people decide not only their scope, but the type of practice they do or what they go into is determined by some personal proclivity or calling, then what do we do for society? So I just want to respond for that. I have my own thoughts, but I want to see how you would respond to that question that's been asked of other people as well. Now for all of you, so I think that you were calling for potentially, or what we're talking about here is a lack of a space to reflect within medicine or medical training or within the hospital. We have things happen. As physicians, we're transformed or affected, yet there isn't much of a room to reflect or talk about that, even within medical education. And so if we are calling for a space to reflect and think and talk about that in a communion of people or community, this occurred in medical school around what happens to the cadavers that we take care of, okay? So I remember at Cornell, and I remember that we have memorials and reflections, and as first-year medical students, you kind of have an event for the families, members of people who donated their body, and then you think about what that meant and what great benefit they had for your education. This occurred in another school in a different country, and because we felt we should have that reflective space. And that country, those people are saying, what the hell is this? Like, why would we be thinking about doing this for this dead body? Right? This does not have anything to do with our sensibilities, but it's being enforced upon us by what we think is a global medical community. And medical education is the same everywhere. And we have a profession that should have similar values everywhere. So where do you take that, right? I mean, I do believe there's a room for this reflection, and we should have that, but I'm not quite sure that's a common language to medicine all over, or it should be.
Thank you. I think I'm going to ask Dan to take that first part of the question to begin with.
Yeah, I'm not sure that I have a completely satisfying answer, other than I think that, part of what I was trying to get at is that I think general surgeons, what they do is they stop bleeding and they drain pus. They're the janitors. They're the sanitary workers. And there's something distorted about the self-perception within surgery that they are the high priests of the inner sanctum of the operating room, and that to have in one way in which I witness, transitive, or may evangelize even, is that by practicing surgery the way that I practice it and focusing on doing those things that others wish not to do and don't value, I am trying to speak the truth and bear witness to the one who died on the cross and was the biggest janitor, cleaning up everybody's mess to some degree. I don't think if there's a shortage, there's not a shortage of the specialists around. So by my choice of doing general surgery in this sort of mundane way, that's where there's the problem. There are not enough who wish to do that anymore. And the hypothetical situation that you raise of, who will provide these services is so hypothetical at this point that I think I don't feel any moral compulsion at this point to really bone up on gender reassignment surgery because people can't get access to it right now. And if I can just say one thing regarding the practices, I have at multiple times attempted to initiate some form of deliberate reflective practice within medical students, within residents, within practicing physicians, to make a space to think reflectively about what we do in either a secular or a theological idiom. But for whatever reason, those attempts never seem to last, and I think that has to do with the fact that, there were several comments that the community of witness, whether in the church, it's the ecclesia, is not sufficiently formed to sustain those practices right now for whatever reason.
Thank you. The point that you made very briefly about the, maybe for reasons that you described, the work of the general surgeon, there is an impending shortage over the next 10 to 20 years of general surgeons that will not be ameliorated, as was suggested this morning in the newspaper, that Walmart will provide all your primary care for the future. They will not provide general surgery because there will not be general surgeons to do it. It's one of the unspoken crises that American medicine is facing. Dr. Allen.
I'm Nathan Allen from Baylor College of Medicine. Again, thanks to the panel for the personal stories that are sort of humbling in their relevance. My question is sort of what your thoughts are about sort of the source of some of this tension and struggle, and a lot of allusions to time and often to lack of time, whether that's procedures that need to be performed at difficult hours, forced windows with your patients, other clinical commitments, increasingly high patient loads. If the real enemy is time, or if time is the scapegoat for a larger shift within the practice of medicine that is making things more difficult.
We'd have plenty of time if we were willing to work for less money.
Okay. Explain that. I didn't get that. No, I...
Well, I'm a little bit facetious, but the time, the reason why we need to see so many patients within a restricted amount of time is because of the finances that are driving the whole thing. And that has partly to do with my expectation and my needs, having incurred the debts that I've incurred and delayed my earning potential along the lines. But I think time is a scapegoat for the fact that we want to have our cake and eat it too.
Although I didn't get that sense from Dr. Michael's remarks that the psychiatric 50-minute hour was just not going to get any longer, and there was no more time in your day. Yeah, go ahead, please.
Yeah, it's a little along slightly different lines, but I wonder if there's a spiritual reality here that has something to do with back to the powers and the principalities. That there are these structuring structures that are ordering time. Michael Balboni's name's already come up once today, but in a paper or chapter that he wrote, he talks about a distinction between time as immanence and time as transcendent. And a lot of the structuring structures seem to be pushing for a horizontal, immanent frame in which we work. Transcendent time would be like what Stanley Hauerwas said about how apocalyptic notions or a dawning gives us all the time in the world to care for one another. I'm getting that slightly wrong. But it's a different notion of space and time, and you can feel that and experience it in walking through clinics and their sterility and the way that they're set up and the way the clock mandates and the way that money mandates. And so, yeah, I think it squeezes out space. What I tried to say in my reflection was that even despite all of that, that somehow, maybe on the strength of the absurd, there are openings and windows, okay, again, by grace, so that, again, space comes open, so that there's a transcendence there. And I kind of wait for those moments, and they sustain me. But yeah, I think that the pressures are immense, and it's hard to figure out how to live well in the midst of those structuring structures, those powers.
Thank you.
Thank you. Dr. Miller.
I'm Ron Miller from the University of California, Irvine. Thanks to Mark Siegler, I'm a clinical ethicist, though, as I'll return to momentarily, I'm also a nephrologist or a medical kidney doctor. I suspect your articulate and compelling presentations may, in fact, have been therapeutic for each of you. And I believe that that is not unique to you, despite your standing and your ability to express yourselves. When we began dialysis at the University of California, Irvine in 1968, we had the luxury of having a psychiatry resident who was quite mature spend time several days each week with our nursing and technical staff, and the debriefing that was done every week of the problems that they faced in their practice was extraordinarily beneficial. My question is, how can we practically allow for the opportunity for medical students, residents, but also for physicians and faculty to have such opportunity for sharing, as you all have done with us, and for sharing with each other these opportunities? I think Dr. Hall partially answered this a few moments ago, but I'd be interested in any other comments about how we can introduce this into the practice of medicine for our own benefit.
Thank you.
I'll try to speak very briefly to that from my perspective on the medical faculty. We have a class called Patient-Centered Medicine. It's essentially our physician-patient relationship course. But in the third year, as students begin clinical rotations, those meetings of 90 minutes come with no agenda at all, other than the students with two faculty mentors talking about their experiences in clinical rotation and coming back to this question of, am I becoming the kind of physician I want to be? And what kind of person am I becoming by becoming a physician? We've actually modeled that on St. Ignatius's model of reflection in the Jesuit tradition, that his idea that you actually see God present in your life better in retrospect by looking back on one's day, back on one's week, back on one's life. And we've tried to begin to model that kind of attentiveness to their professional formation so that they get an opportunity to flag where they see themselves being broken down. At one of my recent meetings, one of my third years told the story about parting ways with her attending at the end of her rotation, or parting ways with her resident at the end of her rotation, and she said, I'm going to go see Mrs. Smith in 3B. And he grabbed her by the arm and said, why are you doing that? And she said, I'm just popping in to sit with her for a little while and hang out. She has a fondness for me, and we just chit-chat about family, and she asked me to take her vitals. And he said to her, she has nothing left to teach you. You have nothing left to learn there. Now, it's a wonderful story for teaching. It's also a heartbreaking story, right? But it's the kind of story that she gets to tell, It's the kind of thing that flags for us as faculty what's happening in clinical rotations, and it gives them a habit of reflection to attend to these kinds of things that can be corrosive to their professional identity.
Thank you. We'll make yours the last question for the panel.
I'm Bruce Campbell. I'm a head and neck cancer surgeon at the Medical College of Wisconsin. And I just wanted to say, Dr. Hardt, your narrative was just phenomenal, and I hope it sees the light of day. It'd be a perfect piece for Peace of My Mind at JAMA.
Thanks a lot.
Actually, Dr. Miller asked my question already, but I'd just be interested to hear from the other panelists. We do Healer's Art courses at our institution and reflective opportunities for the medical students and Schwartz rounds and things like that for the staff. But how do we take this kind of reflective activity or spiritual activity and move it into some sort of scientific mainstream so our more cynical colleagues will wrap their arms around it somehow?
I've been working on the problem a little bit with some colleagues within the church, and one of my close friends has been inspired by a man named Gordon Cosby, who 60 years ago came back from the trenches of World War II, as a chaplain there, finding that those that were part of the church and those that were not part of the church were equally unprepared to meet death. And he thought that that denoted a problem with the way the churches were raising folks, and came to the realization that the churches were structured toward spiritual infancy, and has spent the last 60 years of his life trying to figure out what structures might be necessary to inculcate something other than infancy to some sort of maturity. And one of the things that he is committed to is the fact that it has to remain human on its scale, meaning small. And although his small Church of the Savior has never had more than about 40 or 50 members, it has had incredible influence that sort of percolated out throughout it. So I think that one problem is that I'm not sure that there's a way to scale it up for the scientific community and sort of roll it out. And there are two things that in my experience, in trying to do this, or three things. Number one, it's an additional time demand of which people perceive they don't have enough of. Number two, to have the right kind of exchange requires that people have to be vulnerable. And we've all been vulnerable in a way up here, which is kind of rare, and I think that that's perhaps what was riveting to people. And three, the practice of this reflection requires discipline, and that's something that is anathema in many ways. Although we are very disciplined in our work as physicians, the discipline of self-reflection and what that requires, and being accountable to somebody other than ourselves, to a community that might conform us into an image or something that is greater than ourselves, is something that is sort of deeply resisted. And for those three reasons, it seems to me that every attempt that I've made at least seems to kind of sputter out after a bit of time.
One other thought. I'm not sure that the culture of medicine, the way it is, allows for the fullness of that kind of reflection because of the difficulty or the fear of being shamed and the difficulty with being honest. And it reminds me, I wonder if some of that kind of reflection really has to happen at this point outside of medicine. And it brings me back to the importance of community that may not necessarily be within the institution of medicine. There might be physicians involved in that community to establish places where people can be honest and reflect and feel very safe to do that.
In my 40 years or so of teaching in medical school, the best course I've ever taught was one that Jim Gustafson and I organized around 1975. Jim was here at the Divinity School, and we brought together at monthly rotations the 6 medical students who were on particular medicine rotation, along with 8 students from the Divinity School and actually 6 law students. And that was the interprofessional quality of those seminars. And the cases would come up from the experience, immediate experience of the medical students, but then would be open to the interprofessional commentary by groups outside of medicine. And we taught that course for about 3 years, and it was extremely well received. Things changed and we went on to different things, but I've talked to Farr and to John Yoon about the possibility of reviving something like that as an opportunity for this interprofessional interaction, at least as between medicine and the divinity students. Well, I want to thank the 4 wonderful panelists. It was a lovely meeting.